started, any questions from last time? Any questions before today's lecture? Okay, and we're down one cardiac surgeon. Where's the other half?
I don't know, I actually didn't see him today, so.
Okay, perfect. Okay, so again, this is your guys' lecture. Feel free to ask questions at any time. As you know, these guys know Nick is super interactive. If you don't raise your hand, I will call on you. This whole class, at least my sessions, are meant to help you in the context of your individual careers. So I'm happy to say that there is stuff on pharmaceuticals in space here. There's definitely stuff on cardiovascular adaptations in space, because anytime I find out there's a specific background in this class, I make sure to add to the deck. Okay, so let's get going. The one caveat is, because I've been teaching this class for 14 years now, the deck keeps expanding each time. We actually managed to get through the deck last time. We'll see if that's the case this time. Okay, you guys know my background. I'm mostly not going to reintroduce myself briefly. Just so you know, I practice emergency medicine and aeromedical transport with a background in space medicine and lots of space medicine research, as well as a commercial astronaut. So there's the listed version, and then as well as lecturing here, assistant clinical professor here at the U of A. That is FYI only. You guys don't need to know that. But what you do need to know is what I hope for you to get out of today's lecture. I want you to have a sense of how space is hazardous, why there's a whole field of medicine called space medicine, how we mitigate those risks, what challenges and opportunities are on the horizon, and then how we prepare for space here on Earth. Okay, so let's start with a thought experiment. Imagine you're going to the moon today and you are the crew physician. What are you going to pack with you? Well, in order to know what you're packing, you have to think about your survival priorities. And so how do we think about survival? Well, there's the very well-known Maslow's hierarchy of needs, everything from survival to safety all the way to self-actualization. I would say that in 2025, even more important for food, shelter, and sleep is Wi-Fi. But more seriously, to know what we're packing for, it helps to know the hazards of the environment that we are going into. So what does that mean? A whole laundry list of challenges when it comes to the spaceflight environment. This is kind of a snapshot. We're going to talk about some of these in more detail. So that includes increased radiation. We'll talk a little bit more about that in the middle of this lecture. That includes the increased G-loads of launch and landing. That includes post-flight considerations. It's trusting the engineering of your spacecraft and your life support systems to both protect you from the micrometeoroid and orbital debris, so particles that could kill you if they hit you or penetrate your spacecraft. It's trusting the engineering of your spacecraft to protect you from the vacuum of space, the temperature extremes, extremely hot in the sun, extremely cold in periods of night, as well as the life support system to give you habitable confines of temperature, humidity, and atmospheric pressure. There is the risk of increased radiation beyond baseline from solar particle events. There is the need for interpersonal dynamics, so you have to play nice. You are stuck on a tin can, and it's always awkward when you're asked to, when you're voted off the spacecraft. So you have to be able to maintain those good interpersonal dynamics, but also work well on your own. So there's a lot of personality selection that goes into this. It's what we call an isolated, confined, and extreme environment. So an ice environment. Then of course there's the everyday lumps and bumps of trauma, hazards, abrasions, infections that you may encounter on Earth, and of course the weightless elephant in the room that we have not yet talked about, but the thing that everyone thinks about when they think about space, which is of course weightlessness. And so this is a summary slide. It's a great summary slide about what happens to the body in microgravity, because the summary is that every single bodily system is affected by the microgravity environment. Our bones lose density at a rate of 1 to 2% per month without countermeasures. We'll talk about that a little bit later. So astronauts can become osteopenic or osteoporotic without interventions. Our fluids shift upwards. We're going to talk a little bit more about that, what that means in terms of cardiovascular and CNS, central nervous system adaptations. Our muscles lose mass again without being gravity loaded. our neurovestibular system becomes really confused. So when we're all sitting here in 1G, enjoying this lecture, taking gravity for granted, balance is this careful, delicate interplay between what our eyes perceive as up and down, what our proprioceptors perceive as up and down, and where our body is in space, and then what our inner ears or vestibular systems perceive as up or down based on what the otoliths are telling our cilia about our positions, about our body in space. That all goes out the window once we get to space. And you can even try this. You can confuse your system a little bit right now. You can take away one of those inputs, close your eyes, try to touch your nose. I can do it because I've done this enough times before. My body's trained. The first time I did this, hit myself in the eye. So when you're confusing those inputs, giving conflicting inputs, your body gets very confused. And that's what happens with the immediate transition to microgravity. And so your eyes do not have a reference point for what up and down is. Your inner ear also do not have an reference point for up, down. And then your proprioceptors are hanging out in space. They can kind of still tell your body position, but because there's this input, this mismatch in input, there's a couple of repercussions from that. So in a low consequence, previously astronauts have said, my crewmate's arm kept drifting to my field of view and I kept smacking away. It was really annoying, and then I realized it was my own arm. But more importantly, with the impact on operations is that this mismatch between these three inputs can create this syndrome of symptoms we call space adaptation sickness. So you become intractably ill, vomiting in space. Aside from the images throwing up in 0G, it becomes an operational hazard. So critical activities like spacewalks are not planned within the first week of arrival into the spaceflight environment, because throwing up in your confined space, if you're in a spacesuit, obviously it's gross, but also poses a real asphyxiation hazard. Okay. And the list goes on and on. We know that our immune systems are suppressed, there's decreased T-cell activity, and then also germs are more virulent. And then there's gender-specific effects, there's central nervous system effects. So let's talk about all of those, okay? So teaser about cardiovascular adaptations, there's more to come. So this is kind of a little cartoon schematic about what happens with fluid shifts in space. So again, we're all taking gravity for granted. There is a 1G gradient. Our valves in our veins have to work hard to ensure one-way return to the heart. Now there is a bit of a fluid shift, so the fluid gets shifted upwards towards the torso. The heart perceives this as an increased volume load. And then the legs are like, oh, hey, we don't have any work to do. There's no gravity to fight against. So you see this increased torso size and these chicken legs. But what happens with this decompensation is that upon return to Earth, our veins have decompensated. And so oftentimes, post-landing, you'll see astronauts come out of the capsule. They're being carried out with garlands. It's all pomp and circumstance, but truly it's safety, because it's very, very common. The second you try to stand up, your valves realize, oh, crap, we have to work again, and then you get this condition called orthostatic hypotension, aka you faint. And then prior to that, what happens in the spaceflight environment, this is Dr. Chaki Mukai, I believe she was also a cardiac surgeon, and astronaut with Japan, the Japanese Space Exploration Agency, JAXA. And so you can see what is aptly named the moon face. Here's the 1G condition. You can see the normal nasolabial folds, but you can see this fluid shift. She's very rounded, youthful appearance. So if you want a quick way to get rid of your wrinkles, go to 0G. The other consequence of that is that because your fluids are shifted upwards, your sinuses are congested. So food doesn't taste as good. You feel like you have a cold. So we'll talk about nutrition a little bit later, but that does have impacts on what food astronauts will find palatable. Okay, let's talk about CNS impacts. So despite having 60 plus years of human spaceflight on the record, the beauty of having more access to space and more specialized studies is the surprises keep coming. So this is the spaceflight associated neuroocular syndrome. And basically this is a relatively new kid on the block, only discovered in the past 20 years or so, when astronauts on longer duration spaceflight were saying, hey, my vision is funny and it's not getting better. And this is a constellation of symptoms thought to be due to impaired cerebrospinal fluid, so that's that proteinaceous brain and spine juice that bathes our brains and spines, So impaired drainage of that CSF, impaired lymphatic, and impaired venous drainage. That creates pockets of increased pressure that are unevenly distributed around the brain. The eyes are a window to the brain, so our brains connect to our optic nerves. Optic nerve goes into optic chiasm, talks to the brain about what we see. So those increased pockets of pressure tend to be localized around the backs of the optic nerves, creating a consequence of this increased pressure is optic nerve swelling or optic disc edema. You can see that. You can see the pallid post-flight condition here. It's kind of a little bit pixelated here, but it is swollen. The globe shape flattens. The folds on the choroids at the back of our eyes, they get these folds. So this constellation symptoms is called SANS. We tend to see it in longer duration spaceflight, over 30 days. Reasons we don't understand, it affects males preferentially more than females and is considered to be a potential showstopper for Mars because we don't have enough information on how to mitigate it. So the clinical consequence of this, here's probably saying, okay, great, that's enough physiology. What does that mean? So the vision shifts that occur tend to be hyperopia or farsightedness, which again, how are you going to plan for Mars if you can't see well on Mars? Okay, so since we're talking about gender differences, let's also talk about some of the summaries. There are some don't matter, some matter, some don't. So again, we talked about SANS preferentially affecting the male astronauts. When it comes to cardiovascular adaptations, women tend to be more prone to post-flight maladaptations, so that post-flight syncope fainting tends to affect women more preferentially, whereas in men we tend to see more transient cardiac dysrhythmias, abnormal rhythms as they get into the space flight environment. Women, by virtue of having shorter urethras, tend to get are more prone to bladder infections. Men don't have that problem. Overall, when it comes to performance and psychology and working well in teams and cognition, there's no difference between the two genders. Okay, I often get asked about women's health in space. So the summary is woefully understudied on Earth, woefully understudied in space. Part of that is the demographics. This needs to be updated a little bit. We now have 700 plus people in space. Still 14% of that make up women. 1% of that is women of color. And we also have a great heterogeneity of mission profiles. So in this day and age of human spaceflight, we have everything from suborbital spaceflight profiles, same-day missions, to long-duration International Space Station missions, 6 to 12 months. So, and there is a lot of there's a lot of variability in mission duration. The whole of that 700 includes the 12 or so astronauts who've been to the moon. It includes vastly Caucasian male pilots because that's where human spaceflight came from. So we need to know more. We know that, for example, most women tend to opt for menstrual suppression in the spaceflight environment to avoid having to deal with the messiness of a period in space, as well as there's engineering and operational considerations. So the International Space Station toilet only can handle liquids. It views blood as a solid product. So if blood gets into the toilet breaks down, the engineering needs to be redesigned. We'll talk more about reproduction at the end of this lecture, because we have a whole section dedicated to that. So we talked a little bit about this on the gender slide. The other thing I'll mention is women are more prone to the space adaptation sickness. It's not just going from 1G, hyper-G to microgravity where we get that sickness, confuse our inner ears. It's also on re-entry. So men are more prone to the re-entry sickness. Talked about that. We need more information on the underlying platforms, or underlying pathways for gender differences. And then cancer considerations. So we'll talk about this on the radiation slide, but radiation risks are not evenly distributed. All of our tissues have different risks based on the exposure, duration, and amount. And so women may have increased reproductive risks for cancer, e.g. breast and ovarian cancers. And then finally, practical issues. So modular design is good to a certain extent, but we cannot assume that the proportions and the angles for musculoskeletal skeletal design are the same between men and women, and so we see that having an impact on spacewalks because there is no men's spacesuit, no women's spacesuit. So women are going to these pressurized spacesuits. If you've ever been into a pressurized spacesuit, it is so hard to move around them, and so those can cause pressure points and MSK and strain injuries over time. So the other, also coming back to practical issues, we have data from the spaceflight psychology aspects saying that mixed gender crews perform better than single gender crews. But then also on the operational practical side, women tend to be smaller than men, so they use up less resources, less of a use on food, water, and life support. So you may need a lower size of your space habitat if you're going for an all-women gendered crew, but you have to weigh that in the context of how well does the crew perform as a single gender versus mixed gender. So lots to unpack there. So if you're interested in reading more on this, there's a lot of papers I've sprinkled out throughout this lecture. I don't need to go through them all, but if you want further reading on a specific topic, the links are all there. Okay, let's keep talking. A while ago, I had a dentistry student in space, and he wanted to know, is our teeth affected in the spaceflight environment? Yes. Aerospace dentistry is a whole field of space medicine, and it makes a lot of sense. They are an extension of the bone. They lose their porosity, their enamel can be compromised in the spaceflight environment. And also, if you've ever had a dental infection, you know how painful they are. You do not want to encounter that in the spaceflight environment. From the Mir days, we know that there are cosmonauts who had to deal with intractable pain for 2 weeks. Your job is already hard enough as an astronaut. Let's not make it any harder. So how do we mitigate space dentistry issues becoming acute? So astronauts go through rigorous dental screening, and they're classified into one of 3 oral health classifications, class 1, 2, 3. So class 1, we have good oral health. You aren't expected to have any kind of dental intervention for the next 12 months. All the way to 3, you have oral condition that if you do not mitigate pre-flight is expected to result in a dental emergency within a 12-month period. So let's treat that and let's mitigate that from becoming an issue, a loose crown, a pulpitis, an abscess, because again, let's not treat that in space unless we have to. The other confounder is, aside from microgravity and the porosity and the enamel of the teeth being affected, we know that there's the hyper-G phases of launch and landing, so that's 3 to 4, depending on the spacecraft, depending on the mission profile. But if you have an unplanned mission re-entry, you enter on what we call a steep ballistic trajectory. So if you needed to evacuate the space station post-haste, you could. There is a docking vehicle on which you could re-enter at all times. It just means that your re-entry trajectory is not favorable. You will be exposed to higher Gs. That could be 8 to 9 Gs. So if you have loose fillings, those are going to come loose. So you also want to make sure that your fillings, your dental work, are designed to stay stable in the face of hyper Gs. And then the other part of that is pressure changes. So if anyone here ever done any scuba diving? So if you scuba dive, you know that you're going from surface pressure and then to higher pressures. And then if you have, for example, cavities that have been untreated, as you go back up, that trapped air in your cavities are going to expand. They're going to cause intractable tooth pain. So you can deal with that exact same type of pressure change and pain due to pressure changes as you go through different atmospheres, most notably on spacewalks. So the risks for diving are the opposite on spacewalks. So you're at 1 atmosphere in the International Space Station. You're going to a slightly lower atmosphere in the pressurized spacesuit to find the balance between oxygenating enough but not fighting the suit because it's so pressurized. I think I have some slides on decompression sickness somewhere in here, so we'll get to those. Okay, so the nice thing about space medicine, if there is an aspect that you're particularly interested in, whether it's AI, whether it's cardiovascular surgery, I guarantee you there are questions to be asked about it. And just to give you an idea, in 2016 in Science, the most comprehensive ever study on astronaut health was proposed or was published. And so this is the NASA Twins study. And basically, there was this really nice case of being able to have a control. There's two identical twins, Mark Kelly, Scott Kelly. Mark Kelly is now the Arizona State Senator. Scott Kelly, I think, is still active at NASA. So Scott Kelly did a year-long mission on the ISS, and because they're identical twins, they're both NASA astronauts, they're both Navy pilots, they thought, oh, we have a built-in control with identical genes. Excellent. So this is very, very interdisciplinary. They looked at everything from the systems level, cognition, performance, to the gut microbiome, to the omics level, proteomics, metabolomics, DNA methylation. And what they found is there are some changes that are transient, some changes that need more further studies. So for example, there were differences in cognitive performance while on station. There were changes in the gut microbiome. However, they returned to their normal pre-flight gut microbiome within 6 months post-flight. I mentioned earlier that we know that the immune system is compromised in the microgravity environment. Scott Kelly was the first person to ever give himself a vaccine in space. He gave himself the flu shot. He mounted an appropriate immune response. Interestingly, we saw that telomeres lengthen in the microgravity environment. That was a surprise. So telomeres tend to shorten as we age, and so that was a very unexpected finding, especially since we know that everything else about spaceflight physiology suggests that we have accelerated aging. Something about the microgravity environment, increased radiation exposure, and highly operational stressful environment causes astronauts to age faster. So the telomeres return to their appropriate length post-flight. So again, very, very comprehensive study. It's a great study. Look up NASA Twin study. Anything that you want to know about any level of physiology or astronaut health probably is covered in there. And like I said, space medicine is continually evolving. The surprises keep coming. So this was an unexpected, unpleasant surprise in 2019 during routine handheld point-of-care ultrasound studies on the space station. An astronaut was imaging their jugular vein, and then lo and behold, there was a giant clot of venous thrombus embolism in the spaceflight environment. And so now we have to ask, does being in this microgravity environment predispose astronauts to blood clots? So if you're in the medical field, you know Virgil's triad, you know that some combination of stasis, injury, and predisposition predisposes patients to blood clots. So that can be a post-surgical state, that can be being static on a long transatlantic flight. Is there something about the spaceflight environment? Now, very, very interesting. So you'll see the name Serena Onion Chancellor here. So mostly we try to protect astronauts' identities, very, very hard with these small n numbers, but you can often look at who is named in the publication to see which astronaut was affected. So, and she's very public about this, it's not a secret. She does talk about how she was the astronaut who developed the VTE. And so there was a confounder. Like I said, many women astronauts opt for oral contraception, for menstrual suppression. In certain populations, these birth control pills can lead to increased blood clots. And so that was a confounder. They did have anticoagulation on the station, and so they initially used I think they injected heparin, and then they switched over to Lovenox. Or vice versa, and then they stopped that a few days pre-flight so that in case of a hard impact, high G landing, they were not more predisposed to internal bleeding or bruising upon impact. So again, this is from 2019, brand new finding, whole area of study. Okay, there are some Canadian contributions. There's lots of Canadian contributions to spaceflight. So we know that spaceflight anemia is a thing. It was initially thought to be due to the dilution of our red blood cells in the volume shifts that happen in spaceflight. But then as of 2021-2022, a group from University of Ottawa also found that there was increased red blood cell breakdown in the spaceflight environment. So now there's an additional reason to see a decreased red blood cell mass in space. Okay, I promised there were cardiovascular specific slides in here. There's a lot. Basically, just to summarize or highlight, so we talked about orthostatic syncope pre and post-flight. We also see signs of accelerated arterial stiffening. That was also a Canadian group that found that. We find changes in the heart shape. So interestingly, initially with the changes in the fluid shifts, we see increased stroke volume, leading to increased cardiac output. But then the heart realizes, oh, I don't have to work so hard, there's no gravity here. So then we see the heart shrinking and becoming more spherical. We also see, interestingly, runs of tachycardias and dysrhythmias that would probably cause those of us who are clinicians to freak out a little bit if we saw them here clinically. So we see runs of ventricular tachycardia, for example, in these astronauts, but they're asymptomatic and they're self-limited, which is super important, because if a patient walks into my ER and I see they're in VTAC, I'm a little bit more excited than what happens with these guys. And then because of these accelerated arterial stiffening, we also see endothelial dysfunction at the cellular level, increased cell death, oxidative stress. And then some combination of all of this leads to decreased aerobic capacity, which we fight with countermeasures, which we'll talk about in part 2 of this lecture. Okay, so hopefully that's piqued your interest, that there's something for everyone in any aspect of space health. Genomics, there's stuff. Cardiovascular, there's stuff. AI, pharmaceuticals, there is stuff. And if you're not convinced, I've included a review. This is from about 2023 from Cells, again, looking at the whole compendium of everything there is to think about in human spaceflight. Okay, so the summary, if someone asks you, what did you learn during Shawna's space medicine lecture, just tell them space is trying to kill you, okay? If you don't remember all of the things that we discussed. So that's just part 1, because everything we've talked about so far, we've been playing it safe, we've been staying relatively close to home. We've been talking about low Earth orbit. So that is only 200 to 450, 200 miles, 450 kilometers above the surface level, right? So you could almost, that's almost the distance, a little bit above the distance between Edmonton and Calgary. It takes longer to drive to Vancouver than it would theoretically if you could drive to the ISS. Okay, so what happens when we go beyond low Earth orbit? And why are we asking this question? It's not just a theoretical question. There is a very real plan. Of course, if you're paying attention to space news these days, the geopolitics around NASA's priorities, funding are up in the air. But the current plan for international exploration for human spaceflight led by NASA includes going back to the moon with the Artemis missions. And the whole point of view of the Artemis missions, well, Gateway is canceled, so we're going to skip that. That is a relatively new phenomenon. The whole point of the Artemis missions is to go back to the moon to establish permanent surface operations, to be able to enable our ability to use local resources like lunar regolith for extracting helium-3, for example, for fuel, to do science like Earth observation, sun observation, deep space observation, and importantly, everyone asks about Mars, use the moon as a test bed for Mars. So there is more to learn about what happens when we go into what we call deep space. And there is a significant interest from the commercial space sector. SpaceX, led by Elon Musk, definitely has an interest. And with more the rise of commercial spaceflight and increased influence in the current space sector, Mars may be closer than ever, it may not. Okay, so what have we learned? What are our data points? 12 astronauts, 1969 to 1972. That is it. But we know from those Apollo missions, whether they were lunar flybys, whether they were actual moon touchdowns and moonwalks, is that there is more to contend with. So lunar dust, finer than talcum powder, negatively charged, gets everywhere. It clogs up suit joints, and if it comes with you into the habitat, it is a potent eye, respiratory, and skin irritant. So we need to mitigate that. We need to keep up the longevity of our equipment and also protect astronaut health. So for anyone who ever tries to tell you that the moon landings were faked, know that there are thousands of pages of documentation about the biomedical effects of what happened to the Apollo astronauts. If you're there, I don't think I included the link, but there's a great 800-page document called Biomedical Lessons Learned from Apollo. So it's great reading. And if someone tells you the moon landing was faked, know that they put a lot of effort into faking it. Okay? This is a summary from NPJ Microgravity 2022, I think, an overview of lunar dust toxicity risk. So it's a great summary, and it looks at like where we landed versus where we hope to go. Equatorial positions where you have 14 days a day, 14 days a night as your lunar day-night cycle. However, the next area of interest is the lunar south pole, because that's where ice is, because that's where ice can stay in permanently shadowed, cratered regions. So this is the same thing, a colleague of mine put it very succinctly. That is like an alien visiting Earth, taking a sample from the soil of the rainforest of Costa Rica and using that as representative of all of the soil on Earth. Can we make that comparison from Costa Rican rainforest to the boreal forest? I'll let you draw that conclusion. So they make a lot of good points about knowing the assumptions about the ferrous silicate negatively charged particles, and the size, the texture, the charge, the makeup, and whether that can be generalized to the rest of the moon, and then how that's been simulated, how we can continue to simulate, and how we can plan for future missions. Let's talk about radiation. We've talked about it a little bit. It becomes more relevant in the deep space and exploration class missions, because the summary is the higher up you go, the more radiation you have to contend with. So these are the Van Allen belts of the Earth. And so when you're here, little dot, pretty close to the surface, low Earth orbit, you are still within the protective confines of the Van Allen belts. So any higher energy ionizing radiation, so sources of that would be solar particle events, aka solar flares, and background cosmic galactic radiation tend to get filtered out. So we have it pretty good here on Earth. We take a lot for granted. A lot of the radiation that we would get higher up, we don't see here on Earth. So just to give you a basis for comparison, here is a handy chart from the European Space Agency. And so if we can just taking out the trying to compare sieverts, millisieverts, just take baseline exposure, what we're all getting here in this classroom in a day on Earth as 1 unit of radiation. If you're taking a transatlantic flight from New York to London, you'll get 40-fold that exposure, but again, it's a limited duration flight. At the level of the ISS, now you're losing a little bit of that protection, 250 times the exposure as you would at Earth, at ground sea level. So close to a year's exposure in a single day, and now when you're outside the Van Allen belts, 700-fold. Okay, and now like we said earlier, all radiation protections between different organ systems are not created alike. So we see a propensity to be affected by the eyeballs, blood-forming organs like the spleen, bone marrow, reproductive organs, the gut. And then also we have to take into account the duration of exposure, the acuity of the exposure, and the dose. And so, does anyone here watch any science fiction? Who's here has watched For All Mankind? Okay, I'm speaking to the wrong audience, but so in science fiction you'll see sometimes there's a massive solar particle event, and so that is actually a real threat. In fact, it was only by luck in the 1970s that the Apollo astronauts nearly missed being hit by the most potent solar particle event that we've seen in modern times. It knocked out entire electrical grids, and it was only because no one was in space at that time. It was in about 1976 or so. I think it was a Gemini mission, and there was just months of no one happening to be in space. And the estimates were that if anyone were on a lunar mission at the time, it would have been fatal. It would have required, the dose received would have been required an immediate return to Earth and treatment for acute radiation sickness, as well as have been career ending. Okay, so if you want the numbers, here is how we think about, so here are some examples. Blood-forming organs have an annual limit that is much lower than the eye and lower than skin, for example. And then we have career limits as well. So you can see on Mir, over the course of a Mir, 1 year Mir mission, we actually exceeded the annual limits for blood forming organs by a bit. And so as we talk about deep space missions, we need to talk about how we mitigate radiation through shielding, interventions, pharmaceuticals, textiles, and possibly even gene modification. Okay, so any Hitchhiker's Guide to the Galaxy fans here? Okay, you guys need to up your science fiction game. That is your homework. So there's this quote in science fiction from Douglas Adams that says, "Space is big, space is so vastly, hugely, ginormously big, you wouldn't believe it." And that applies for telecommunications as well. So when we talk about the distances involved with communications, again, we talked about maybe distance between 2 North American cities for the ISS. There is no time delay. It's real-time comms. They can Facebook up there. In fact, they do have social media up there. When we talk about the Earth and Moon, it's a 2.2 second round trip delay. So about a second from the time I say hi and you hear that hi. With the communications architecture that we're building for Artemis and the infrastructure around that, it'll probably be a 10-second delay, but again, totally reasonable to have a real-time conversation with noticeable delays. The story changes when we get to Mars, because depending on the alignment of the 2 planets, your ability to have a round-trip conversation changes. So at their nearest conjunction, 3-minute one-way delay, so 6 minutes round trip. Noticeable, but you can still get real-time comms. At their furthest conjunction, you will have a 23 to 24 minute one-way delay, so up to 48 minutes round-trip delay. If you are running a code and you have no idea how to run a code, does that work? No. Okay, let's make the problem even more nightmarish now. Say the sun is between the Mars and Earth, okay? Now you have complete communications blackout for 2 to 3 weeks. You are on your own. So how do you get your crew to survive on Mars? We need to move towards Earth-independent medical operations. You need to increase the autonomy of your crew, and we do that through emerging technologies like AI and VR, which we're going to talk about towards the end of this lecture, as well as how we think about our mission profiles. That's a lot. So let's talk about, if anyone says, what did you learn about from the exploration class part of the space medicine lecture? Tell them about the RIDGE framework. All of this can be summarized as RIDGE: radiation, isolation, and confinement. So we'll talk about crew selection and the personality type that does well in these missions. Distance from Earth, so we just talked about that and how that affects telecommunications. Altered gravity environments. Thus far we talked about 1G, we talked about micro-G, we talked about hyper-Gs for launch and landing. We did not allude to the 17% gravity on the Moon, 38% gravity on Mars, because we just don't know. There's so much study to be done around that. We just need to start getting gravity profiles for what partial gravity does, and then everything else that falls under hostile environments. So that includes the lunar regolith exposure that we talked about and dust toxicity. We haven't yet talked about altered day-night cycles. So the 24-hour day-night cycle that we all take for granted is upended. On the International Space Station, you're rotating at a rate of 1 sunrise and 1 sunset per 90 minutes, 16 sunrise-sunset cycles per 24 hours. Depending on where you are on the Moon, if you're at the equator, 14 days of day, 14 days of night. That is going to mess with your circadian rhythm. And then Mars sounds nice, 24 hours, 39 minutes. You're being shifted by 40 minutes every day. By the time you get to day 12 or 15 of your mission, you're 12 minutes opposite mission control on Earth. So it has consequences. Okay, so now that I've managed to stress you out about all the ways that space can possibly kill you, let's talk about the tools we have at our disposal so that we can talk about how we keep humans healthy and thriving in space. I'm just going to do a quick time check. Perfect. Okay, so let's talk about the tools we have at our disposal. Keeping humans healthy and healthy in space starts with prevention. So at the agency level, we talked a little bit, I think, about the difference between agency and commercial astronauts. Last time, we'll talk about that more at the end, time permitting. If you are a NASA, if you're a Canadian Space Agency, if you're a European Space Agency astronaut, you're heavily medically screened. I often like to say that the road towards becoming an agency astronaut is littered with the hopes and dreams of medically disqualified candidates. Hypothyroidism, diabetes, high calcium troponin scores, high blood pressure, and a lot of other things. If you are a NASA, if you're a Canadian Space Agency, if you're a European Space Agency astronaut, you're heavily medically screened. I often like to say that the road towards becoming an agency astronaut is littered with the hopes and dreams of medically disqualified candidates. Hypothyroidism, diabetes, high calcium troponin scores, mango allergies, previous MSK injuries, mango allergies because there's cross-reactivity with latex, hypothyroidism. There is no end to the number of medical conditions that can get you disqualified. So it starts with rigorous physiological, psychological, physical screening and selection, and then it continues with pre, in-flight, and post-flight rehab. So there's monitoring and countermeasures we'll talk about on the next slides, and then nutrition as well. So we talked about one piece of the nutrition puzzle. It has to be palatable. So it has to be increased texture, it has to be increased spicy, savoriness, because we're congested. So sriracha sauce is the most in-demand item on the station for that reason. Despite all of this, there is no physician guaranteed to be on station. Why would there be? You have 24/7 support from the flight surgeons on console between the 5 international station partners. So at this time, it includes the USA with NASA, Canadian Space Agency, European Space Agency, JAXA, Japan, and Russia, Roscosmos. You have real-time support. So you don't need a physician. Once upon a time, the crew medical officer, there will always be a CMO, had 40 to 60 hours of training. And then with the astronaut curriculum getting inflated, it's now more 15 to 20 hours. So if the astronaut is so motivated, they can circulate to the emergency rooms, learn to throw in IVs, learn to throw in catheters, because urinary obstruction ends up being sometime an issue. There are also onboard medical kits, medications, procedures, and protocols. And finally, there is risk mitigation. So anyone with an engineering background may recognize this as a risk matrix. And so when we talk about how we mitigate risk, we look at the likelihood of something happening and the consequence if it occurs. And so if someone has COVID and then we send them up to the station, we know that they are going to be more congested, they're going to have fluid shifts, it's going to be a closed, confined space. We know that their immune system may be knocked out, COVID may mutate. That is not a risk we want to take. What do? We swap them out and we put their mission back up in. And then also there's pre-flight quarantine. So NASA was doing it before COVID made it cool. There's a 2 to 3 week, 2 weeks quarantine period through which the astronauts will go through, because we know from the Gemini era that when we didn't do that, astronauts got colds up in space. It was a bad time. If something is low risk and low consequence, we're not going to dedicate mission resources to de-risk, because we only have finite resources. So that's the first tool we have in our arsenal, prevention. Let's talk about the International Space Station checks crew health care system. And so we talked about prevention, so there's primary all the way to tertiary prevention, monitoring prevention. So there's the environmental health system. This is more on the engineering side. This is the life support system that looks to make sure that our atmosphere is within habitable confines of temperature, humidity, atmospheric pressure. Countermeasures. We have not talked about the countermeasures and health maintenance systems. So let's do that right now. How do we prevent that bone density and muscle mass loss? Astronauts famously have to do 2 hours of aerobic and resistive exercise 6 days a week. So you better like exercise if you want to go to space for a long term. And so that helps weight load those systems and prevent that muscle mass loss and bone density loss, because it's the weight-bearing bones, it's the axial parts of our skeleton, so the spines, the femurs, the pelvis, that tend to lose that bone density. And so here's your fun bit of trivia. There is a treadmill on the ISS. It is called the Colbert, after Stephen Colbert, the comedian, because once upon a time NASA held a competition to name their newest US module. Stephen, being a lifelong space nerd, got all his fans to overwhelmingly vote to name the new module the Colbert. NASA said we can't do that, but what we will do is name our new treadmill the Combined Load-Bearing Ergonomic Resistance Treadmill. Colbert, space loves their acronyms. This is no different. How do you weightlift in space? Like, I can bench 400 pounds in space, no problem. It's because there is a resistive hydraulics machine, so you can still do your bench presses, your squats through hydraulics and resistive, which provides resistance. There are also dedicated medical packs. There's everything from an advanced life support pack to a basic life support pack. There's medical packs. There is a decompression sickness pack in case someone exhibits signs of decompression sickness after a spacewalk. There is a crew medical restraint system, because if you are trying to perform a procedure in microgravity, it really doesn't help if you as the proceduralist are floating away and your patient is as well. There's dental care, and then of course telemedicine capabilities. Okay, very, very, very multidisciplinary, so very appropriate for this class. So there's flight surgeons. Typically, they're trained in aerospace medicine. There are some exceptions to that, but there's also pharmacologists, nutritionists, a lot of rehab, a lot of OT, occupational therapy, physiotherapy, and then basically every single specialty within medicine is represented. There are urologists, for example, who sit on console as flight surgeons. There's OBGYNs. So if there is a discipline, there is a role for it. We already talked about the 24/7 flight surgeon coverage. Okay, that's all well and good, but humans can only do so much. So let's talk about computer modeling tools that we have to be able to predict and keep our astronauts safe. This is a snapshot of the integrated medical model from NASA's exploration medical capability. And basically, it takes the medical supplies on the International Space Station, and if you say, hey IMM, I like the contents of your kit, but now help me plan for a 9-month mission to an asteroid with a crew of 6 rather than 4, and here are my acceptable limits of risk with respect to loss of crew health index, crew productivity index, and loss of life. These are the constraints. And then the IMM will integrate what is on the ISS medical kits and then extrapolate that based on those constraints and mission profile. You might be saying, okay, well that's all well and good, but Shawna, there's a serious flaw here. Like, what happens if you end up using your same amoxicillin for a respiratory infection and then a bladder infection, and you have another type of infection? You cannot assume, that's very, very linear, you cannot assume that your medical kit assumptions are going to hold up. To which I say, I'm glad you brought that up. Here is the next iteration of the, where did it go? Oh, we went away, okay. The next iteration of the medical IMM is the MedPrat. So the Medical Extensible Dynamic Probability Risk Assessment Tool. Again, it's all acronyms, call it MedPrat. It's way simpler. This is based on neural networking and Bayesian modeling. So you have a much more dynamic model that allows you to both insert different adverse events as well as countermeasures. So you can generate a series of possible mission outputs. Okay, so we talked about the hazards, we talked about tools. What actually happens in space? We need to prepare for what has happened historically, as well as what are the worst case scenarios. So IMM is based on the top 100 list of integrated medical model medical conditions. So this includes stuff that has happened in space, stuff that is kind of boring but will impact your performance all the time. If you have a congestion headache, we know that with a lack of convection on the ISS, CO2 tends to pocket when we're breathing out in front of our faces when we sleep, and so that can cause CO2, vasoconstriction headaches. And then there's repetitive motion injuries. So there's that. There's the terrifying stuff like cardiac arrest, mass hemorrhage, mass trauma, sepsis. So there's also planning for that. And then there's somewhere in the middle where it's terrifying but not life-threatening, like diarrhea in space. Don't think too hard about that. Okay. What has happened in space? So we have lots of data from Space Shuttle, from Mir, and luckily, as you'll see, the reason we keep going to space is that's the things that are annoying but not life-threatening that happen. So the majority, the percentages will differ based on the source. 40 to 60% will get that space adaptation syndrome, that intractable throwing up in space. Most of that will resolve within 40 to 72 hours. 24 to 72 hours is kind of the time frame that we expect. We see things like bladder infections, respiratory infections, dermatitis. Fun fact, the skin on the bottom of your feet peels off just like a snake because you're not putting pressure on your feet. So why does your skin on your feet need to exist? So that happens. It's not considered a medical concern. It's just something that happens, but also beware of what's floating around you in space. We do see psychology playing an effect, a small effect, about 2% behavioral signs and symptoms, and there's some really great books about that around psychology and spaceflight. So that is from the shuttle era. Here's the MedPrat. So this is the, as you can see, Again, a lot more dynamic, less linear than IMM. You're able to account for adverse events, fixed events, random events to demonstrate a series of probabilities. Okay, what else do we have at our disposal? So this is the latest iteration of what has come out of the exploration medical crew capability. And so this is IMPACT. This is another modeling tool that looks at what we have in terms of subject matter expertise, what we have in terms of pre-mission training, what we have in terms of key performance indicators, and how we can use that to demonstrate procedural training for fixes on mission. So there is a lot of computer modeling that goes into this, and a lot of interdisciplinary, interconnected thinking. So the other tool that NASA uses is directed acyclic graphs. That is just simply a way of saying, how are these things connected? So we pick a medical condition, in this case, psychiatric disorders. We look at the other hazards of spaceflight that could contribute to this: isolation, confinement, radiation, distance from Earth. We look at the possible worst-case mission outcomes, and then we look at what are the risks from the human itself, risks from the mission itself, and contributing factors, what might have a cause, what could be a cause. And basically, this is a way of thinking through what do we know, what don't we know, what do we need to further de-risk. So that is an example. Again, all of this is nicely publicly available. Okay, so we're starting to fill in the blanks now. We've talked about the hazards, we've talked about the tools, we've talked about de-risking, we've talked about what we will pack. So how are we going to pack? Who here is really outdoorsy, does a lot of hiking, camping? Perfect. So when you hike, can you bring it all with you?
No.
No, it's the backpacking principle. You can only fit what you can carry and that will fit in your backpack, and also you can only carry a certain amount. You can probably carry more than I can, but everyone will have their limit to when it comes to mass. So NASA calls this the backpacking principle. I like to call this the Aladdin principle because it's phenomenal cosmic power to get to space. Itty bitty living space once you get there. So what are the packing considerations for space? What we have to bring with us ideally has to be low cost, low volume, low mass, low power draw, easy to use, have a long shelf life. Astronaut time is at a premium. At the ISS, astronauts are scheduled down to the 5-minute mark. If you're asking for 2 hours of training time, you're probably going to be asked to bring that down to 15 minutes. And in a crisis, the astronauts should not be expected to relearn their training, but should be able to have something that is easy to use. Okay? How does this all fit together? This is from a life sciences lecture, and it looks at how we bring in the clinical aspects, the human performance aspects, how it all fits together with the spacecraft, and then everything from the person level to the mission outcomes to the environment and the craft, and how they all fit together. And then we run through scenarios: best case, worst case, unlikely case, for training, routine, emergency, survival scenarios. There is a lot there. There's a whole reason space medicine is a whole field. So when we're talking about design, how does that low mass, low volume, low cost, modular, easy to use, long shelf life, how does that translate into an actual medical kit? Courtesy of NASA, we have real life snapshots. So you can see it's Ziploc bags all the way down. Light things are going to be put with light things. The advanced life support will be put with the advanced life support. The procedural tools will be put with the procedural tools. Medications for light things will be put with medications for light things. Here you have ibuprofen. If you put all of your ibuprofen in one Ziploc bag, less waste. Open it up, ibuprofen is everywhere. So it's ibuprofen bag inside a Ziploc bag, inside a Ziploc bag. Same with the Tylenol and aspirin. Here is one of the advanced, this must be the respiratory medical kit. You can see the bag valve mask, you can see the trauma shears here. So this is red, highly visible, highly modular. Velcro is your friend in microgravity to be able to grab what you need to save a life. And which one is this? This is also part of the respiratory care pack thing. There is an AED on station. Luckily, we've never needed to use it, but again, it helps to be prepared for things that can be mission ending and cost lives. So all of this is to convince you there is no end of risks when it comes to humans in space, especially when it comes to exploration class missions. NASA has a very nice, publicly available, easily interactable human research roadmap. So all of the risks that we talked about are still surface level. If you want to know more about how NASA is thinking about radiation, human performance, thinking about how humans may not interact well with the hardware design, you can see with their laundry list, you can actually click on these and you can see, is it still an active issue? How has the risk board mitigated it? Where do they stand on that? And it just goes on. And so there's a lot of considerations. So at one point, there was the risk of skills decompensation. And so if you were the crew medical officer, never stuck an IV in your life, learned to do it on Earth, aren't called to use that skill until you're on Mars 9 months later, your poor patient is going to look like a pincushion. So how do you de-risk that? Some of the ways that I've worked on have been looking at creating VR, medical procedural scenarios, to be able to maintain that muscle memory and practice in spaceflight while adhering to the principles of low mass, low volume, low cost, easy to use. I haven't made up the midterm questions yet, but I am harping on the design principles because hint, that comes up a lot. So if you need to memorize any slide, it is the design principles of spaceflight. Okay, summary of the section: space is hard, space is expensive, space is trying to kill us. How do we prepare for spaceflight without going to space, knowing it is expensive? So here's a question. What does the ISS have in common with a rural village or an Arctic medical deployment or an underwater research habitat? This comes back to the term we talked about at the beginning called isolated, confined, and extreme environments, ICE environments. And so they are all examples of remote, resource-limited environments. So maybe we can use these. They're analogous in some way to the spaceflight environment. Maybe we can use these to train for the spaceflight environment. Because of that correlation, we call them analog environments. So this next section is kind of my own compendium of experiences in analog environments and how we use them to prepare for the spaceflight environment. Okay, we've harped on gravity a lot, so let's talk about how we de-risk gravity before we go to space. This is parabolic flight. It is also known as the Vomit Comet. We fly with the National Research Council in Ottawa, so we are flying no higher than a commercial airliner. Commercial airliners fly at 40,000 feet. We fly at 17,000 to 19,000 feet. And think of a roller coaster, but with your airplane. So when you're going at the top of a roller coaster and you feel your stomach lift into your chest for a second, it's because you're falling at the same rate as your vehicle for a split second. When you do that with your airplane, think of riding your bike up a hill, you're accelerating upwards, building up that potential energy, and then you're falling at the same rate as your airplane. That gives you 18 to 20 seconds of microgravity at a time. And so you might be saying, well, what can we do with 18 to 20 seconds of 0G? Turns out a lot if you stack your parabolas. So in this case here, we are testing the functionality of a commercial intravehicular activity spacesuit. Does it function when the visor's down, when it's ventilated and pressurized? Can you perform the fine muscle motor and gross muscle motor movements that you need to? You can also stack protocols. You can do science feasibility studies. So for us, when we do our training for spaceflight, it becomes a workhorse for us. We've been working with the National Research Council for 10 years. A picture says something, but a video says so much more. So here's what that looks like in theory. If that video will play. Okay, I'll play it at the end in the interest of time, and the video is included in the links. But highly recommended if you ever have the opportunity to be in 0G in a spacesuit. It's a good time. But you might be saying, okay, I need something more than 18 to 22 seconds. That only gives me so much. You need to do better. But I think that's a very astute observation. So what if we need longer periods of microgravity? We can simply offset our weight. So this is gravity offset. This is a run-through we did with the Canadian Space Agency in 2019. We now house the system at our home site in Florida. So when I say our, this is pointed to my International Institute for the Astronautical Sciences affiliation. So this is a different type of spacesuit. This is an EVA or extravehicular activity spacesuit. Like I said, space is full of acronyms. This is the kind that you'll see when you're doing a moonwalk or a spacewalk because it has added layers of thermal and radiation protection and life support. So if you wanted to simulate fixing a faulty panel outside the International Space Station in microgravity, what you want is unlimited periods of microgravity. And so here, we've offloaded my weight by 99% so that we can be able to have uninterrupted times. And you might be saying, well, it's just you in the suit that's offloaded. And I'll say that's a very astute observation because the hoses that I'm hooking up and unhooking the second I drop them are still subject to 1G. So all of that is to say that with every test bed we have, there's trade-offs, and you have to pick the best one for what you're trying to achieve. Just going to do a quick time check. Okay, we have time. Moving on with test beds. So that all focuses on the reduced gravity portions of spaceflight. We still need to get data on physiological adaptations, technological science adaptations for the hypergravity phases of launch and landing. How do we do that? Centrifuges are one of our best friends. You can also do that through aerobatic flight. So this is some testing we did looking at commercial suborbital vehicle profiles way back in the day, and basically there are specific maneuvers that if you're being exposed to hyper-G as an astronaut, as a fighter pilot, you can do to counteract the increased loads of G forces either front to back, up and down, up to a certain point. So it does become really hard to breathe when you have that increased G load, but there's ways to mitigate it. We learn a lot from living and working above and below the water. So we have some water partners over in Connecticut that we work with to create simulated off-nominal post-landing situations and abort attempts on ascent. So all of that is the fancy ways of saying if your launch or your landing goes poorly, what are your emergency scenarios? And so we have a mock-up of the Orion capsule, that's the spacecraft that will be going to the moon, and in that we simulate post-landing operations. So here's an example. Okay, there's examples of, if you have rough sea state, if you have a toxic gas exposure in the spacecraft, if you have a fire in the spacecraft, how are you and the crew going to get out? Are you going to use the top hatch, the side hatch, and how are you going to get to your emergency inflatable raft? We can also use the buoyancy properties of the water to simulate microgravity. So here, NASA has the world's largest neutral buoyancy lab. They have 6.2 million gallon pool. They have a near full-size mock-up of the International Space Station entirely underwater. So when astronauts are doing something high risk that requires a lot of practice, they don't practice for the first time in space, they practice in the pool because they're using the buoyancy properties of water to maintain that weightlessness. We have a slightly more modest 14-foot pool over in Connecticut where we build mock-ups of airlocks and simulate specific examples of procedures. So here, myself and my EVA partner need to come to the near field. We need to stay tethered to some aspect of the station at all times. We have our umbilicals giving us comms and air supply from the top side. We have safety divers, and then we're coming to use a pistol grip tool, don't call it a drill, we've been told, to swap out the faulty module and then come back. So it's really good for giving you that unlimited neutral buoyancy time. Okay. We talked about isolation, confinement, and crew dynamics being a key factor to mission success. So how do you confine your crew without sending them all the way up to space? Underwater research habitats are a great way to do that. So I've done 2 aquanaut missions. They're called the Nautical Experiments in Physiology, Technology, and Underwater Exploration. Don't need to memorize that. Missions at the Jules Undersea Lodge in the Florida Keys. So over the course of 2 missions, we spent a total of 11 days underwater doing key experiments in technology testing, physiology that might inform our understanding of human physiology in spaceflight. The really cool part of being underwater, there's a couple of them, is that in this environment, you're at a hyperbaric pressure. So increased pressure. So everything from the food you bring with you, if you're bringing a bag of chips, crunches down. If you shake your soda, open it up, because of the pressure, you're not going to have as much of a mess. But it also has impacts on your sleep and your overall physiology. Plus the view isn't bad either. It also gives you a good test bed for simulating testing technologies that might need to be deployed to ice environments. And so here we're testing a mixed reality point-of-care ultrasound device to see its functionality in a space-like environment. And so this is what I mean when I say the view isn't bad. So this is an example of another underwater research habitat. This is the Aquarius Reef Base, also in the Florida Keys. This is where NASA sends its astronauts, where CSA sends its astronauts to become aquanauts. Aquanaut is simply being breathing the ambient pressure around you in a hyperbaric environment for 24 hours or plus of being in saturation. And so here you are at 60 feet, essentially 2 atmosphere. And so if you are in this habitat, you are really confined. You're kind of like the fish in the fish tank. You're wondering who's looking at who. But the important thing to note about why this is a good analog is this is where the principles of decompression signals come in. When you're in saturation, you need to ascend at a set rate so that the bubbles that have dissolved in solution in your body come out at a safe, slow rate. Without that, they can lodge in places that are bad, in your joints, in your bones, in your vessels, causing everything from joint pain and bruising to seizures, coma, even death. That's why we ascend at a set rate. Why does this matter? If you have an emergency in the Aquarius reef base at Nemo, you need to either figure out whether it's worth the risk of ascending immediately, or can you take your decompression period? Your decompression period at Nemo is 16 hours and 47 minutes. That's a long time. For comparison, when you're on the ISS, you have an immediate need for evacuation. There's a fire, toxic exposure, there is a medical emergency. You can get back to Earth on a ballistic trajectory. It won't be comfortable in as little as 3 to 6 hours. So it actually takes more time to get to the surface from Aquarius reef base than it does from ISS. So that is the value of a underwater research habitat in building those crew dynamics and self-sustainability. There are also dedicated lunar and Mars simulation analogs all over the world now. There used to be a few, now there's a lot. So this looks like Tatooine. This is actually in the Utah desert. It is called the Mars Desert Research Station. You have your habitat, you have your greenhouse, you have your observatory, and your workshop. And basically, you are bringing your crew dynamics and your science and objectives with you. If you suit up, you have to go outside, lest the Martian environment kill you. And so it's another way of simulating what it's like to live in a mission. And the geology is absolutely stunning and mimics the redness. The geologic formations do a great job of mimicking what you might encounter on a Martian planetary EVA. Okay? So there are also lunar analogs. There are more and more all across the world, but you can also create your own lunar analogs. So this is Cinder Lake, just outside Flagstaff, Arizona. This is one of the planetary geology evolutions we did as a team. And what NASA did in the 60s is to create this rocky, craterous lunar landscape, is they just set off explosives to create a cratery, rocky formation, and they had the Apollo astronauts go through with their jetpacks and their gear to simulate how they would do an EVA. And so we've built on that, and we've gone to the same place, done the same training, and with the lessons learned on ergonomics both from the spacesuits used on Apollo as well as the tools, we've redeveloped and redesigned some of the tools for geologic EVAs on the moon. Okay? You don't need to go out to the middle of nowhere. You don't need to build your own Mars habitat. You can also use operational environments to help prepare for space flight. So this is an example of that. So this is a research flight that we did in high level in 2017, and basically very, very operational environment. We had a research pilot, we had myself as the mission specialist, payload specialist, and we had a mission specialist to determine our trajectory. And what we're doing, it's an unpressurized craft at 19,000 feet. You need to wear oxygen, otherwise you will do what the mosquitoes did at 19,000 feet, fall to the ground. And what we're doing is we're testing this new tomography instrument to get more data on these clouds thought to be related to climate change and get more information about the three-dimensional structure. Okay? And then you can simply take the resources out of your environment to build these, build this skills and preparation for a spaceflight environment. So here's an example. I teach space medicine through AAIS as well, and so what we do is we turn folks with no medical background whatsoever into a medical MacGyver. We build upon principles of wilderness medicine, triage, recognition, treatment, assessment, and then build in spaceflight simulation scenarios. And we take away their resources. So we might be in the middle of Arizona, but when we do our simulations, we do them out in the field. And it's critical because there's an increased need to have safety and healthcare standards regardless of where you are and what kind of environment you are in. okay? So we'll see how far we get. I think we're only more than 2/3 of the way through the lecture. But let's talk about the next horizon in space exploration. So we are talking about the horizon, the next challenges in human spaceflight. And the big one is exploration class missions, going to Moon and Mars and beyond. And we've talked about all of the challenges and how resource limited it is on Mars. But what if we turn that question on its head and said, well, what if we got rid of the challenges? What is the gold standard? What if we got rid of all the constraints on Mars? And the answer would simply be, what if you could terraform the planet? What if you just brought another Earth with you, got your geomagnetic field back? You bring your circadian rhythm back to the 24-hour day-night cycle. You give yourself increased gravity. You give yourself an atmosphere. That would be nice. That is shooting for more than the moon. So how does that compare to healthcare? So our challenge is to meet the same standard of healthcare in any remote location, including Mars, as we would on Earth. So then why don't we go a step further and say, what if we could not just meet that standard of care on Mars, but what if we could surpass it? So how do we do that? This is where the technology and the future of medicine part of this course comes into play, because there is a lot from science fiction and what's happening in the world right now that we can do to inform our plans for Earth-independent medical operations. So taking inspiration from science fiction, what if we could bring a rotating partial gravity spacecraft with us from Space Odyssey 2001? What if we used exoskeletons to allow decompensated astronauts to perform meaningful work once they got to the red planet? What if we mitigated the risk of skills deterioration by simply uploading information straight to our brains? What if we said, well, what if we just skip the 6 to 9 month period of travel to Mars and simply get to Mars faster through a faster vehicle or teleportation? Or what if we said that is too much risk, we're just going to send avatars of ourselves? That is all science fiction, but sometimes the future is closer than we think. So VR and AR have a big role to play in space flight. They've been used for just-in-time training with augmented reality for emergency procedures. Through my affiliation with Luxonic, the company, we've done some work for the Canadian Space Agency, creating a virtual reality diagnostic imaging workflow so that you can consult with specialists in real time to review diagnostic imaging while overcoming the mass volume power constraints of the spaceflight environment. There's a video of what that looks like, but we will skip over that for time, if this will comply. We've also created procedural training modules for spaceflight, so to come over the risk of skills mitigation. What about more future looking? What about genetic engineering and enhancing our astronauts? So we know that we're sending astronauts into this high radiation, high risk environment. So what if we genetically enhance them with elephant genes to make them more radiation resistant? And Nick's look on his face right now is saying, why would you possibly splice an elephant genes into a human? And it's not to make an elephant astronaut hybrid, I promise. It's because elephants don't get cancer. They have so many copies of the P53 oncoediting gene that they are able to edit out DNA damage. So the idea, the proposal that was covered in the MIT Technology Review is, if you were sending humans into this high-risk environment, don't you have an ethical obligation to protect them as well? And so that is what the proposal to engineer elephant genes into astronauts is. But the future is happening today, because this is a snapshot of the Rodent Research 19 experiment that came back from the International Space Station in 2020. You see this adorable, muscular, jacked-up little mouse here. That is a mutated mouse that has more muscle mass, more bone density. It has something called the ACVR2B neuromuscular blockade. This is its wild-type little cousin here. They had 4 groups: wild-type, mutant, flown, and non-flown, and this mutant mouse had less bone density loss and in some cases gained more muscle mass than its control. So NASA is literally engineering mighty mouse, and that's what's going on in space research today. So there is a lot more here. I will not cover it because I think we're at time. Maybe I will finish off with the technology components at the beginning of next lecture and take 10 minutes to do that. But this is all to summarize that space is a hazardous environment. There are a lot of challenges, and there's no end to the challenges. There are a lot of offers that technology, emerging technologies, everything from synthetic biology to 3D printing to AI can offer us. We'll finish up at the beginning of next lecture. Basically, if you're wondering if there's a space for you and your interests in space, I promise you there is. So that is it. I'm going to pause for questions, but I also know that we're at time, so if you need to go, I won't be offended. All right, questions? Or extending into silence, one of the two. So most of next Thursday's lecture will be very, very hands-on. You guys are going to come to work. We're going to put you to work on innovative thinking. So it works better when we have more people. Bring a friend if you have someone that makes the mention they have extra time, they have nothing to do, bring them. If we have at least 6 people, it'll be best.
Yeah, it's a long history of that. This class is, in theory, open to the general public. So I mean, that's one way to think about it. So on Thursday, you can bring anybody, who wants to come. Yeah.
Good. Thank you.
Great.
Thank you very much.
Take care.